Mohamed, in the last programme we talked about the drugs that you use to get a couple to full term and a happy pregnancy and delivery. But some of the drugs that you used are considered controversial by some. How do you respond to that criticism?
I wouldn't consider them controversial myself, because almost all these drugs are available and they've been used for many years, albeit for different reasons. Like, for example, one of the drugs that we've used now for almost 15 years has been developed to treat people who've got rheumatoid arthritis, and it's been looked at its safety and whether you can give it to people. And people who actually use it for rheumatoid arthritis, they stay on it for life. We use this drug sometimes for people who've got what we call elevated cytokines, which can sometimes be associated with implantation problems and how the embryo can attach itself to the uterus and grow throughout the whole pregnancy. And we did find this to be very helpful for that group of patients. We only give them like a 2 doses of this drug, and sometimes even 1 dose is enough to lower the levels down. So in my own experience, I've seen it work, and we've published this as well. So it's not like we kept it to ourselves. And we've been applying this for a lot of patients who have failed repeatedly anywhere else, and they seem to have done very well just by introducing something like that. And most of these patients, funny enough, they seem to produce very good embryos in previous attempts when they fail, but they never really get pregnant. So it begs the question, okay, why they're not getting pregnant, which again point out to the fact that the problem is not the embryo quality, it's actually what happens next when the embryos go back into the body. And if you don't address this problem, you're just going to be wasting embryos, good embryos, all the time. And then there will come a time when those good embryos are not going to be there anymore because the patient has become older, or she's been pushed very hard with medication many times. So you have to be very careful, and you need to make sure that you at least have a hint or an idea about where the problem is and try and do something about the problem. And I think a lot of people working in this field, their emphasis is always on the embryos, and I think this is rather incomplete, and I think we need to try and look beyond the embryo and understand a little bit more about what happens after the embryos go back into the body.
What is the criticism of the drugs that you're using, and where does it come from?
I mean, some people have said that there's no evidence that it works, but IVF is a very complicated sort of procedure. There are many variables, and sometimes it's very difficult to try and assess the effect of one variable and see exactly whether it works or it doesn't work, and so on and so forth. And like anything in medicine, I think if IVF was about to be sort of started today, I think you would have never been able to do it in this country or any other country, because of all the talks about you have to have the randomized controlled trials and so on. And it's very difficult to do randomized controlled trials for this particular type of treatment, because most patients who have failed repeatedly before, they don't want to be randomized in a trial not receiving the treatment, so that in a few years' time we might establish whether it's working or not. They would rather be put on the drug and take a chance on it. And the results are very encouraging. So, I mean, if I was a patient, I'd probably do the same.
What are the risks with these drugs?
I don't think there is a risk as such, because as I said, all these drugs are available and been prescribed for years. It's not that it's something new that has never been tried. It's been tried and tested.
But for different...
But it doesn't matter, but you're still giving the drugs to people, and you know exactly how it works, or whether there is... Any drug, if you look at the pamphlet, they will tell you there are associated potential risks, but none of the risks that we know of are worrying enough or serious enough to stop us using it. And as I said, we've been using it since 2012, so that's 17 years. I don't recall actually ever seeing any big problem with the use of any of those drugs. The other drug that we use is a drip that sometimes can help balance a certain abnormality in the body and improve the implantation potential. And one of the drips that we use is something that has been prescribed for patients during the pregnancy if they have low platelets, because they can bleed very heavily at the time of birth. And people have been prescribed this IVIG sort of drip throughout the pregnancy for 9 months. I mean, we normally give this like 1 drip before putting the embryos back. And then we keep assessing the levels. And if the levels are still high, if the patient is pregnant, we try and keep the levels under control, so they may have 2 or 3 more drips after that. And it has worked. I mean, we've seen a lot of good results with it. And the thing about this type of patients, having failed repeatedly before, so every time they have at least an embryo or 2 embryos put back, so they come to you having had 8 embryos back, no pregnancy. The only thing you change is to identify that there is an implantation problem. You give them this medication, you put 2 embryos because you have to put 2 embryos because they failed many times before. And a lot of them end up with twins, meaning that this was the problem. It wasn't the embryo. Once you've removed this problem, the embryo implant and develops straight away.